Good morning, good afternoon, good evening. Welcome everyone to Core Data's webinar on life sciences developments, revised AdvaMed code, and expansion of Sunshine. So just to give you a brief history, we did run this webinar a few months ago. It was very well received. A lot of good positive feedback from the attendees and questions. And just to introduce our speakers today, this morning, joining me is Matt Wetzel. Matt's a good friend, a senior counsel at Aiken Group, Aiken Gump, Strauss and Hoover and Field LLP. I'm having trouble getting to the whole name today. But Matt was instrumental in the process that led to the revision of AdvaMed that came out earlier in the year. So he's a leading authority on the subject and on the topic. So very pleased to welcome Matt in our conversation today. And just by way of introduction, my name is Mohammed Awais. I'm founder and CEO of Core Data. We work with pharma, device, biotech, and life sciences organizations around their compliance technology needs. So with that, I want to pass it over to Matt because the rest of the webinar is going to be his show, just talking through the AdvaMed revision. And for the audience members, if you have questions, there is a questions and chat window on the GoToMeeting webinar panel. Feel free to send those in. We'll take them either as we go through the presentation or towards the end, but we'll make sure that your questions or queries are answered. So with that, I'll hand it over to you, Matt.
Well, great. Thank you so much, Mohammed. I really appreciate it. And everybody on the webinar today, thanks so much for dialing in to listen to an update on the AdvaMed code and the Sunshine Act expansion. And as Mohammed mentioned, I joined Aiken Gump earlier this year. I returned to private practice after spending the past couple of years as the Deputy General Counsel at AdvaMed, where, as Mohammed mentioned, I had the good fortune to lead the most recent revisions to the AdvaMed code. We did a webinar earlier this year, as Mohammed mentioned, and we wanted to do a repeat just to give folks one more shot at listening to some of these updates, especially as we get close to the effective date of the AdvaMed code revisions, which go into effect, as you all know, January 1st, in just a little over a month. And also to talk briefly about some of the Sunshine Act expansion and some of the work that will go into enhancing your systems to account for the proposed or the expanded list of covered recipients over the course of the next year. So to start, the main goal of our presentation today is to review some of the AdvaMed code revisions that go into place on January 1st. And just to give you a little foundational knowledge on the AdvaMed code, the AdvaMed code is a very long-standing document, and in fact, it's 25 years old at this point, launched originally in 1993. It had been originally revised at the beginning of this century, 2003, and was revised again in 2009 as a result of several changes in the ecosystem for medical device companies. First, the Massachusetts and Vermont laws were coming out. As you recall, that was about 10 years ago when those transparency requirements were first launched. In addition, the Sunshine Act was a very hot topic of discussion at that time, had not been implemented or enacted. It wasn't enacted until 2010, but was certainly a source of much discussion. And many of you might recall that in 2007, there was a series of settlements in the orthopedics industry for kickback allegations that really sparked interest in the industry and enhancing its profile from a compliance and integrity perspective. And so the revisions to the code were launched in 2009. Since then, however, as you all know, we've had a significant amount of government guidance, informative settlements, enforcement actions in the area that have really dictated how industry enacts compliance measures and best practices. We've had a lot of guidance from the U.S. Department of Health and Human Services, Office of Inspector General, and DOJ on issues like transparency, issues like inventory management. So we'll be talking later today about consignment and demonstration equipment and the like. And then also in physician-owned distributorships, this has been an area of increasing enforcement. In fact, just recently we saw, just earlier this month, 2 weeks ago, we saw a new False Claims Act complaint against a South Dakota neurosurgeon and his physician-owned distributorship, as well as a settlement about a month ago with Sanford Health in South Dakota with respect to False Claims Act allegations associated with that same distributorship. So an area of interest and continuing interest that really dictates how the industry looks at its best practices. We've had other associations in that intervening 10 years launch their own codes of ethics. In fact, I had the good fortune over the course of the past few months to speak with several of these international societies around the world about their code development process, and many of which are both following the AdvaMed code lead in making revisions, but also thinking about geographic and market-specific dynamics that would impact their own codes. And then, of course, the AdvaMed code in China, which became effective January 1 of 2016. And of course, I had the good fortune of working with AdvaMed on that launch and some of the initiatives around that code, and can tell you that some of the best practices discussions in China sound very familiar to the best practices discussions that we have in the United States. So continuing with the tradition of a strong industry code, some of the goals with this revision were to update language that might have required some additional clarification or around which there was some confusion over the past 10 years, addressing evolving legal standards, and then improving user friendliness. And we'll talk about some of these changes. Some of the core new features of the code that I do want to highlight, and I always highlight in these presentations, because I really do think they're important aspects and elements of the code that could very easily be overlooked if you're just looking for a particular topical area. First, the cornerstone values. This is a set of values that were it's really an amalgamation of existing values in the code, as well as additional concepts that have arisen over the past 10 years or so. We incorporated these values as what we call cornerstone values in the code, a lens through which a code user can review a program or an arrangement or an interaction with a healthcare professional that either is addressed under the code, and you might be looking for some additional guidance about how to handle the arrangement, or an arrangement that's not addressed under the code, but perhaps would require the code's perspective, so to speak, on how to appropriately interact with an HCP in that arrangement. So some of the values, and not to read them, but to really emphasize their importance here. First, innovation. The industry is focused on developing innovative products, innovative arrangements, and really moving the ball and advancing the ball on innovative products. Education. One of the main goals of the industry is to educate HCPs on how to safely and effectively use product. Integrity, ensuring that business is conducted with integrity, avoiding perceived and real conflicts of interest. Respect. This is about respecting the independent clinical judgment of the HCP. In other words, an interaction with an HCP should not unduly or inappropriately influence that HCP's independent decision-making with respect to the patient's care. Responsibility. Here we have a broad value of promoting socially and ethically responsible business practices focused on protecting patients and their rights and their safety. In other words, when you're faced with a particular interaction and it may not be clear how the code applies, really think about this concept of social and ethical responsibility. And then, of course, finally, transparency, a real buzzword for the industry over the past 10 years, but a buzzword with some real meaning and depth behind it. Conducting interactions with HCPs fairly openly and transparently has been really the goal of the Sunshine Act, and the goal of a lot of the significant and impressive efforts of the industry to comply with those requirements and even to go beyond. Interpretive principles, the current version of the code contains some concepts peppered throughout the introduction about how the code applies. We took these principles, consolidated them into one introductory section, so you have a one-stop shop for understanding the practical application of the code. For example, the geographic reach and scope, the impact on personal interactions with HCPs. What do you do if you're a company with multiple business lines or with combination products? We incorporated into the code a new compliance program infographic. Many of you know that certification for the AdvaMed code requires certification that you have an effective compliance program in place. And that certification is based on the traditional, quote, 7 elements of an effective compliance program. And as we looked at the code, we realized that the conversation about 7 elements has changed. It's evolved over time, especially the past few years. Now we see guidance that talks about 10 elements, 11 elements, 12 elements, and so we really wanted to provide a map or an infographic, as we call it, for companies that are looking to certify to the code as to what that means. And so we've drawn that out here in this infographic. Would recommend that you pay attention to this, not just in implementing your AdvaMed code requirements, but really in evaluating and assessing your compliance program more broadly. In addition, we added a glossary to the code. Again, what might be viewed as somewhat of a small change or a small revision, sort of a minor concept, but this really, the use of a glossary enhances the user friendliness and the readability of the code dramatically. Currently, terms are defined throughout the code, but they're peppered throughout, whether in the main body of the code or throughout the FAQs. In fact, we found a couple of definitions that are, a couple of words that are defined multiple times throughout the code consistently, but not identically. And so we really wanted to take this opportunity for rewriting the code to provide a one-stop shop for users at the beginning of the code here. And so please take a look at the glossary as you review the code requirements. One of those core terms, as we mentioned before, is healthcare professional. So this is really one of the key substantive anchors of the code. The code is about interacting with healthcare professionals. So how do we define a healthcare professional under the code? It's any person or entity that's authorized or licensed in the United States, we're talking about United States or U.S. healthcare professionals, to provide healthcare services or items to patients, or somebody who's involved in the decision to purchase, prescribe, order, or recommend medical technology in the United States. So it's not just individual clinicians, although individual clinicians are part of the definition. It's also provider entities, so it's people or entities, individuals or entities that provide care, but it's also administrative personnel at provider entities. For example, a hospital purchasing agent, and the like, somebody who may not necessarily hold some sort of medical license, but does have an involvement in the decision to purchase product. We're not talking about HCPs that are bona fide employees of the company. So for example, if you have a chief medical officer who happens to be an MD, but if they're a bona fide employee of the company, we're not focused on those interactions. It's HCPs who are outside of the company. And of course, another important aspect is geographic reach. How far does the code extend? And what we've said here is that we're talking about interactions with U.S. HCPs, whether those interactions occur outside the United States or inside the United States. So in other words, the code follows the HCP wherever they're licensed or authorized to practice. And this has a significant impact on transparency. We'll talk about the transparency expansion in a moment here. But thinking through the scope of the Sunshine Act, the scope of some of the other laws that are applicable, and the scope of the AdvaMed code, we really tried to make sure that the geographic reach here was similar. We do have a couple of initial poll questions, and I'll turn it over to my core data colleagues to ask these questions.
Thank you, Matt. We'll be launching the poll shortly for the audience members. You should be seeing a poll on your screens. If you can quickly respond, two choices, yes or no. Looks like almost 60% of the folks have voted, so we'll give a 30 seconds. Okay. All right, so 67% folks have adopted and 33% have not done so yet. Let's go to the next polling question. So I guess this would be relevant for the ones that haven't adopted, because the ones that have already adopted, probably not of a good meaning. So looks like almost half the folks have responded, and I guess the results are almost 93% are moving forward with the adoption of the revised version.
Great. Well, thanks so much for that, and thanks so much for responding to the poll questions here. Of course, the code, as mentioned, goes into effect on January 1, and we're all happy to help if you need assistance in adopting the code and its provisions. And feel free to ask your questions as well as we proceed throughout the webinar here. Some of the key provisions of the code, we wanted to really spend some time highlighting the changes associated with the code. We have many training materials that are available for you all on the code, but to really focus this session on some of those revisions we thought was important. So first, consulting arrangements with HCPs, one of the really core high visibility interactions with HCPs relates to consulting arrangements. Of course, consulting arrangements for valid, legitimate, bona fide consulting services are so important to advancing innovation, to patient care and patient safety. And what we've done with the AdvaMed code, the majority of this section remains the same, but we've added some clarification to some of the concepts that have either created confusion or where there were more than an ordinary number of questions over the course of the past few years. So first, legitimate need. The code requires there to be a legitimate need that's identified in advance before contracting with an HCP for consulting services. We describe what that means, legitimate business need, and how that is important and why that's important for consulting services. We talk about the importance of mitigating HCP's conflicts of interest. This is a topic that comes up regularly and is especially pertinent to consulting arrangements that could lead to a conflict in an HCP's interest. We talk about the importance of developing an objective and consistent fair market value methodology which could involve either an internal assessment or a third-party assessment to adopt objective criteria that are applied consistently across the board for compensating HCPs. And we also talk about the limits on sales involvement in consulting selection. As we developed the code, we had a significant opportunity to interview and engage with the sales force and sales representatives of many medical device companies just to understand the reaction to the code on the ground. And this was one question that came up time and again in our conversations. Why does the code limit sales involvement in consulting selection? So we included some concepts in the consulting section to really just explain why that is. Of course, we don't change the restriction on sales involvement, but we do talk about why we have it. In addition, we updated and consolidated a few sections on company-conducted product training and company sales and promotional meetings into one section on company-conducted programs and meetings. The provisions of the current version, Section 3 and Section 5, were so similar that we thought, we could probably create a much more streamlined code if we consolidate these sections and then just include some different call outs for different types of programs, whether that's training and the requirements for faculty to be technical experts or justifications for out-of-state travel or out-of-town travel. we felt that including these provisions under the same section would be helpful for a user of the code. And really the key is looking at who's the faculty, who's the attendee, where's the program established and set up, what kind of business courtesies are you providing, and do you have a legitimate need for the program? Substantial time and attention was devoted to third-party programs and how companies can support third-party programs under the code revisions. And here we're talking about educational programs, independent research grants, charitable donations, and commercial sponsorships. So first, we do distinguish under the new code between the concept of an educational grant, which is funding that's intended to defray the cost of educational content, versus commercial sponsorship, which is a fee that's paid in exchange for some sort of advertising or promotional opportunity. So you can think of it like a grant is a company provides a grant to a third-party conference organizer because the company is a good corporate citizen, supports legitimate and bona fide educational content, and really wants to help the third-party organizer in its efforts to educate the HCP community. A commercial sponsorship, on the other hand, is a payment that's made in exchange for an exhibit space or an advertisement or some other sort of promotional opportunity where the company does receive a benefit in return. So we wanted to highlight those two distinctions in the code. There had been a lot of confusion about that over time. We kept the existing guidance for charitable donations and independent research really primarily the same. There weren't a significant amount of changes there, so be cognizant of those sections, but please know that there was not a lot of revision there. On educational programs, a couple of key changes to highlight for you all. We do now include a section of the code that permits a company to send a speaker to a third-party program, provided that A, the speaker is speaking on the company's behalf, the third-party organizer approved and requested the speaker, that the company's effort to send the speaker complies with any accreditation standards or standards that the third-party organizer has. And finally, that the speaker makes quite clear in its disclosures to the audience that he or she is speaking on the company's behalf. We included a review process checklist, a sample set of questions that companies can use when evaluating either educational grants or commercial sponsorships to understand some of the compliance issues there. And then we've added an FAQ. We've added a couple of FAQs on what sorts of benefits HCPs can receive at a third-party conference from an industry sponsor, and then also on conducting satellite symposia. Got our next poll question here, and let me turn this over to the Core Data team.
Thank you, Matt. Let's get to a quick poll from the audience. So what is your company's top compliance concern with respect to third-party educational grants? You have a few options. We'll give 30 more seconds for folks to chime in with their opinion. This is a slightly longer question than the yes/no that we've asked before. So we'll keep it open for another few seconds. And while people are voting for, so we have some results. Ravish, can we display the results? Okay. 45% for conference organizers hosting entertainment or recreation. All right, over back to you, Matt.
Okay, great. Thanks so much. So one of the new sections that we included in the code relates to what we call jointly conducted education and marketing programs, commonly called co-marketing arrangements. This is a long-standing practice in the industry to collaborate and to conduct education and marketing programs with HCPs. So in these arrangements, the company will advertise or market or educate on its products and the HCP will educate on his or her capability to perform the related procedures. There have been some settlements in this area with the government, and as a part of the process for assembling this guidance, this new section of the code, we took a look at the settlement language there and some of the restrictions that the government has placed on these programs, and we've incorporated those into the AdvaMed code, an area that is somewhat higher risk, but we think when structured appropriately can be very, very valid. So what are some of the restrictions here? Well, first, there has to be a bona fide legitimate need for the arrangement. It can't be set up just to benefit the HCP or to somehow assist the HCP in their own business development. This is about the company having a need and the HCP having a need, and they're coming together to achieve those needs or to meet those needs together. The code requires independent controls so that the programs are not considered to be unlawful inducements. We do encourage and insist that companies require HCPs to follow their company policies, especially with respect to off-label discussions or discussions about health economics. And we require that both parties contribute fairly and equitably towards the activity and towards the payment of costs. In other words, it can't be a program where it's just the HCP speaking about his or her capabilities. It has to be both parties participating in the arrangement, and both parties need to contribute towards the costs of the arrangement, including the HCP. And then, of course, written documentation of the arrangement and maintaining appropriate files and information in the event that a company is asked about the programs, but also B, it ensures that both parties are following and understand their individual roles and responsibilities. Travel and lodging. The current version of the code, as you all know, does not contain a standalone section on travel and lodging, but this is an area of quite a few questions for the code. In fact, I would say it's one of the areas where we receive the most questions on the code. So we decided to consolidate all of the existing references to travel and lodging into one section of the code. Again, another one-stop shop for a user, so that when they do have a question about travel, question about lodging or venue, they have one section to turn to, new section 6. And in short, anytime an HCP is traveling and the company is paying for out-of-town travel costs, there must be an objective and legitimate reason for that travel. It can't simply be because it makes it easier for the HCP. It can't simply be that the HCP requested it. The company has to have a very objective and legitimate reason to bring an HCP into a centralized location. For example, a technical training that couldn't occur remotely. It would have to be in person. All travel and lodging costs should be modest and reasonable, thinking about sort of class of travel, the type of hotel where an HCP is put up. Of course, controls on timing and location are encouraged for companies to adopt. We don't recommend specific controls, but we do believe that each company should tailor their travel and lodging appropriately and subject to controls, especially in terms of timing and location. And then, of course, meeting venue, we include some additional language and additional concepts around meeting venue. Those being a centralized location, think about ease of access, think about the surrounding region and what its implications are, and then think about the season of the year. So, for example, if you're hosting a program in Park City, Utah, in the winter, that's going to pose a higher risk of being viewed as a problematic program than if you were hosting a program in Minneapolis in the winter. No offense to my colleagues from Minneapolis, one of my favorite cities, but it is a not generally thought of as a destination location in January. And then, of course, we added language about personal travel and the inability of companies to pay for that. Similarly, with the section on modest meals, we included some updates here. The basic principles do remain the same. The setting and the way that the meal is delivered needs to be conducive to a discussion. It's secondary to an educational or business or scientific discussion, the meal shouldn't be the primary area of interest or focus of the interaction, that the focus should really be on the educational discussion with the meal as the background. Location and guest issues as well remain the same. We did add language in the revised version of the code to encourage companies to develop policies on meals, including a spending cap. We've put out, or AdvaMed, I should say, has put out really robust benchmarking data on meals. And the idea here is that in response to a settlement, a kickback settlement from 2018, the AdvaMed settlement on meals, that the time is right for companies to really take a look at this high volume area of interaction with HCPs, and to make sure that that your policies are up to date and appropriate. Educational and patient benefit items and the ban on gifts and the ban on entertainment and recreation, these remain the same. In fact, there are no changes to this section other than to update some of the examples that were included in the educational items section. In fact, this was one of the sections that triggered the revision to the code. We had originally talked about DVDs, DVDs and iPods and the like, technology that's really kind of out of date at this point. We wanted to update those examples, which we did. We did engage in a discussion about the ban on life event gifts. As many of you know, the current version of the code prohibits giving gifts even in recognition of life events, weddings, deaths, births, that kind of thing. And we did really deeply and closely examine this question. Should the industry loosen its restrictions here? And at the end of the day, we determined not to do that. So we left that life event gift ban in place. Let me turn it over to the Core Data team for our next polling question.
Thank you, Matt. So we'll launch the next question on the screen. Ravish, if you can help me with that. Should be a very straightforward question. Does your company have policy on providing meals to HCP? I guess more interesting question would be, how do you monitor against it? But let's start with the first question, and looks like quite a few people have responded. So we'll close out the poll to get the results. Okay, looks like almost everyone has some sort of a policy, which is I guess expected, and that's a good sign. Okay, do we, I guess the next question is probably more relevant, which is which one of the following attributes are included in your meal policy? I guess we should have had all of the above, or some way to multi-select. Okay, I think that's a difficult one, but if you can maybe select the ones that I guess you'll be able to select one. But if you can only select one, just select the one that you already have, that you're quite sure of. The next feedback for ourselves is next time we'll make the poll be multi-select on this as well. Okay, so we'll close out the poll and see the results. Looks like most everyone has some sort of a per person spending limit as part of their policy, which is good to see. Nobody voted for restrictions on alcohol consumption, but perhaps a topic for another day. Moving it back to you, Matt.
Great, thank you so much. Really appreciate it. Some of the additional sections here, and we're drawing to a close on the AdvaMed code provisions here. But first, the section on health economics and reimbursement information, we changed the name of the nomenclature of this section just to make it a little bit more concise and consolidated. Didn't really make changes, a couple of grammatical edits to this section, but nothing substantive other than to clarify that anytime you provide assistance with health economics and reimbursement, whether that's supporting an HCP's efforts at coverage, different interactions as they relate to things like pre-authorization and appeals, that any of this sort of assistance should never be provided with the goal of relieving an HCP or their institution of their responsibility to perform those functions. So you can certainly train on it, you can certainly assist with it, but you can't provide this effort really as an unlawful inducement. The section on evaluation and demonstration products, here we also renamed the section demonstration, evaluation, and consignment products because of our new language on consignment. The sections on demonstration equipment and evaluation equipment didn't change substantially. We did add a new FAQ, a couple of FAQs, I believe, on appropriate reasons for the evaluation arrangement. Included some reminders that transparency requirements may apply to these sorts of arrangements, but the message itself, the substance itself, really remains the same. We added a new provision on consignment. Many companies didn't think this was necessary. Many did think it was necessary. So an area of a little bit of disagreement among the industry as to whether it should be included. But we're starting to see more and more interest from the government and more interest from outside parties on how companies manage and put controls around the types of products or no-charge products that they provide to their customers, consignment being one of those examples. And there's some fraud and abuse risk associated with consignment programs, and therefore we made the determination to add some high-level language and guardrails on consignment. So, of course, it should be subject to an agreement addressing the terms of the arrangement, and that companies should consider implementing controls around consignment, such as taking periodic inventory and reconciling discrepancies, and then, of course, removing expired product and making sure that when the provider uses product, that it's appropriately documented in the file. We added two new sections to the code that address longstanding, but sometimes what are perceived to be somewhat controversial types of arrangements with HCP. So first, communicating for the safe and effective use of medical technology. This is a very high-level section about communications on off-label uses of product. And here, essentially, it describes the ways in which this sort of information can be delivered through a company representative with appropriate expertise. Communications need to be truthful and not misleading, and any information on off-label use should be identified as such. And it really encourages the larger point of this section is to really push companies to adopt policies and controls around off-label communications. It's a risk area for the industry, and there's certainly many instances in which an off-label communication can be handled appropriately. FDA has issued many guidance documents on the topic, and so we wanted to take this opportunity to incorporate these areas into the code. And then company reps that provide technical support in the clinical setting, again, a long-standing practice that we as an industry have felt is appropriate and necessary in many instances. For example, procedures that involve complicated technology often require a significant number of additional devices and tools at the surgeon's ready, but also a really deep and complex understanding of the technical functioning and controls of a lot of the equipment that the industry produces requires somebody with that deep knowledge to be present in a setting. But we do include 5 high-level guardrails for companies to incorporate in their policies. First, you have to be present at the request and supervision of the HCP. It should not just be assumed that the rep will be in the room. Rather, the HCP needs to be in charge. The rep cannot make any medical decision-making for the patient. Their function is solely to be the technical expert on the product. Compliance with applicable patient privacy requirements and hospital and facility policies like credentialing. And then, of course, this should not be intended to eliminate an HCP's overhead expense. Again, this should be an arrangement where the company rep is necessary to serve as the technical expert on the product. I would point your attention to a couple of tools and resources that are available on the AdvaMed website. I've got these on the screen here. I defer to my former colleagues at AdvaMed for any additional tools and resources that they've produced, but please know that these resources are available. A couple of concepts across different industry codes that I wanted to take a few minutes to highlight for you all. So first, the conference vetting system. This is a question we get a lot about whether AdvaMed or others require some sort of approval from the industry association before a company can support a third-party program. We don't have that under the AdvaMed code. The MedTech Europe code, I believe, is one of the few that does have that sort of centralized decision-making process. Direct sponsorship. This is the concept that has been prohibited by the code since the 2009 version. So this is a long-standing prohibition under the AdvaMed code. And this is the idea of a company directly paying for an individual HCP's travel, lodging, and registration fees to attend a third-party conference. We prohibited that behavior, as I mentioned, since 2009 under the AdvaMed US code. AdvaMed China code and APAC-Med and MedTech Europe all issued a prohibition on direct sponsorship effective January 1 of 2018. Satellite symposia, these are addressed in somewhat similar ways across the different codes, but I listed some of the concepts there. Third-party organized procedure training. These are specific types of third-party programs that are focused on practical hands-on technical training. We don't address these under the AdvaMed code. We treat those just like any other third-party program. But the AdvaMed China code and the MedTech Europe code include some additional guardrails around those types of programs. Consignment, co-marketing, off-label, and reps in the clinical setting. These are all concepts that are addressed under the AdvaMed US code, but not the China code, APAC-Med code, and MedTech Europe code. I would point out, however, that there are many, many industry codes around the world. For example, the Canadian Association, the Canadian MedTech Association has a really great, robust code that they recently released. The South African Medical Device Association, SAMED, a really terrific group, and they have a code as well, a really very robust, very comprehensive code. The New Zealand and the Australian societies also have robust and comprehensive codes. So there's a lot of materials around the world on interactions with HCPs, and I would encourage you to really dig into each of those codes, many of which are fairly closely aligned. There's a lot of effort on the association level to even better align those codes. But for example, if your company is interacting with an Australian HCP, turn to the Australian societies or the Australian MedTech Association's code for really good guidance there as well. Some of the changes that we can expect over the coming months, coming year, and this has been a slide that really hasn't changed over the course of this past year, and I looked at it again this morning and didn't really see a need to change it. Again, I regularly evaluate this slide, but the Sunshine Act expansion we're going to talk about here in a moment. There's still a real need to validate and align the scope of your HCP policies to make sure that the transparency aspect of Sunshine is something that doesn't cause you any concern. In other words, you need to be able to stand really confidently behind payments and interactions with HCPs, especially in light of the transparency requirements that we see. And so the code plays a really important role with that. We've seen proposed value-based rules issued by OIG. These are proposed revisions to the anti-kickback statute, safe harbors. I could do another couple of webinars on this topic, and in fact have delivered those webinars. But these are really significant changes to how the OIG will evaluate value-based arrangements. And there's some question as to the degree and scope of medical device involvement under those interactions, but we can expect to see some further changes over the next year in that area. Again, additional tools and resources for the code, which I've already talked about. And then the industry continues to be under a significant amount of scrutiny. And so really the code itself is intended to be a good anchor for the industry as we address those concerns. Sunshine Act expansion. So many of you know. Let me actually start with the poll questions from Core Data, and this relates to some of the new changes under the Sunshine Act.
Thank you, Matt. Just quickly for the audience, I think this is should be again one of those where everyone in the audience is somehow affected. But will your company be impacted by the expansion of Sunshine? And Ravish, if you can help me launch that polling question, please. So we'll leave it open for a second here. But this has been a conversation over the last year in almost every customer conversation I've been to, and I guess the fundamental questions around how do we ensure that the data is captured, how do we ensure that the data is accurate, and all the things we had to do with the HCPs now have to be done for these additional covered recipients. So thank you for the responses. We'll close this poll out and look at the results. It looks like almost 90+% of the audience members today are going to be affected by Sunshine. So very, very high percentage. And let's go to the next quick polling question, which was around which type of practitioners does your company interact with? I guess it should say most frequently. So if we can have your responses there as well. The choices are nurse practitioners, PAs, clinical nurse specialists, certified registered nurse anesthetist, and certified nurse midwife. So we can get a quick sense of the type of recipients you regularly interact with or most frequently interact with. That'll help us with the conversation to keep it moving along. I think we have a good number of responses, so let's close out the poll and see the results. Looks like a lot of audience feels the interactions are with the PAs and NPs are the ones that are the most common, I guess, after HCPs. So wonderful, and thank you for those responses. Over to you, Matt. Back to you.
Great. Thanks so much. So as many of you know, a little over a year ago, 13 months ago, Congress passed the Support Act, which finally expanded the definition of covered recipient under the Sunshine Act. This was something we've been watching since, I want to say 2015 was maybe the first time they issued a proposed expansion to extend the Sunshine Act to physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives. This tracking would begin on January 1, 2021, the first disclosure being in 2022. CMS issued proposed regulations to expand the Sunshine Act per the Support Act. Earlier this year, its proposed physician fee schedule came out in July, and the final physician fee schedule came out just a couple of weeks ago. And really, to be quite frank about it, CMS did not add a lot of information here. So the proposed reg and the final reg simply indicates that companies will be required to report on these additional practitioner types, but does not address how, for example, CMS will validate those practitioner types. What data will CMS use to develop its own list of who these folks are? And really, the final rule basically says that there will be guidance issued over the course of the next year about how to collect information on these practitioner types. The final rule also expands the nature of payment categories. It consolidates a payment category for continuing education, but it also now incorporates a new section on loaners and capital equipment that's loaned or used for evaluation purposes beyond 90 days. and then also payments associated with corporate transactions. There's a new category for that, which those are very, and also for the write-off of bad debt. These categories were really important to add because they were disclosures that CMS always required companies to make. If you look back at their informal guidance through FAQs, these were areas that CMS indicated companies needed to report on, but there was no relevant category. So if, for example, you had to disclose a $50,000 payment to a physician because perhaps you purchased, your company purchased her startup company, so you purchased her stock and you purchased her stock for $50,000, let's say, that $50,000 payment would be disclosed under Sunshine, and potentially the category that fit was gift. There's no miscellaneous category, as you all know. So recognizing that that's certainly not a gift, that there's a valid and legitimate reason for that, CMS did expand the nature of payment categories, and I think appropriately so. CMS also indicated that it will now be requiring companies to add the, quote, device identifier portion of the unique device identifier, the UDI, associated with medical devices, and to reemphasize that drug companies will be required to report the national the NDC, the drug code, for their disclosures as well. So just something to pay attention to as you progress through 2020 and begin to collect information on these areas. I've included this slide from a previous presentation that I did about the impact of the Sunshine Act revisions on state disclosures. I'm not going to really go too much into this, but just note that there are some state disclosure requirements that will now be preempted due to the expanded Sunshine Act. Some of the issues that we see with the expansion are just really the sheer numbers associated with the additional HCP practitioner types. So, for example, you have 88,000 active physician assistants, 165,000 active nurse practitioners, but many of these folks hold multiple licenses, and states document and detail the licensure requirements in different ways. So this could be an area of significant confusion and difficulty in implementation, and we would point your attention to the fact that states again, sort of document and keep track of licensure in very different ways. So there's still a year before tracking has to begin, and we would encourage you all to use that year wisely as you look at your operations and how you collect that information, and train your sales reps and the like. It's quite likely that there won't necessarily be a reporting list that CMS issues the way that they do for teaching hospitals and the like. So just something to be thoughtful of as you still have 13 months before the effective date. And with that, that's it for the substance of my presentation today. We've got a couple of minutes left. Let me turn it over to the Core Data team for any questions from the audience or any additional discussion.
Sure, Matt, we have a few questions. I'd call them out and would love to get your responses for our audience members. So we have one question from Ali. She says, outside of pharma and medical device, do you see value for clinical laboratories implementing AdvaMed and Sunshine Act in their practice?
That's a really good question. I think that there's certainly room and opportunity for clinical labs and other types of providers and suppliers to implement either provisions similar to the code, the AdvaMed code or the pharma code, or sort of analogs that make sense for that industry, especially as OIG's and CMS's scrutiny of different participants in the healthcare delivery system increases, what we see is, and what we have seen, especially with the release of the value-based rules, is some additional skepticism on the government's part about the ability of entities like clinical labs to participate under value-based arrangements. In fact, if you look at the proposal for the anti-kickback statute safe harbors that OIG released, they specifically exclude labs from participating under protected value-based arrangements. And I think a lot of the issue that OIG cites to is historical enforcement concerns, and there's a great deal of credibility that an industry can earn by developing these sort of rules of the road, these good compliance principles. The focus on ethics and integrity really, I think, increases a positive profile with the government and would certainly be appropriate. The other thing I'd point out, especially with respect to labs, is the Eliminating Kickbacks and Recovery Act, or ECRA, E-K-R-A. This is also a federal law that was issued as part of the Support Act, much like the Sunshine Act expansion. This is an all-payer kickback statute focused specifically on labs. And so for the laboratory industry to have an appropriate industry code, I think would be helpful, especially as there's additional scrutiny on that particular sector.
Okay, thank you so much, Matt, for that response. And we do have a few additional folks that have been asking for a copy of the presentation. So just to let everyone know, we will post a replay of the webinar. It should be available on our website, and we'll be able to forward a copy of the slide deck as well. So we'll make sure that that's available. We'll also send you email address for Matt if you need to reach out to him directly as well. So you'll have all of that as part of attending the conversation today. So I know it's a slightly low week in terms of activity with the Thanksgiving around the corner. So I want to thank Matt for his insightful conversation today. I know when we had run this webinar 6 months ago, we ran into a lot of technical challenges because of which we weren't able to really walk through in the depth that we did today. So really appreciate you, Matt, taking us through it one more time, and appreciate the work you've done both at AdvaMed and continue to do with the device and life sciences companies at your current firm. And for the audience, thank you everyone for coming, showing up this week, the week of Thanksgiving, and hope you all enjoy your break. And if you have any questions, feel free to send it over to us or to Matt directly. And as I said, we'll follow up with those 3 activities after this webinar is over. So once again, thank you everyone. Thank you, Matt. Thank you, and we'll close this out.